Call the meeting to order. Let's rise for the pledge, please. I pledge
allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good evening, everyone. Catherine, would you please take the roll?
Yes. Director Wallace.
Present.
Director Nicholson.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Director Ethan.
Present.
Okay, Jan, we're going to have the education session.
We are, but before we start, Nancy had asked that I share with everyone that she's had total joint surgery and she's recuperating at home, and she expects to be back in the office at least part-time next week. So we wanted to share that. Ed's going to introduce the education session for us.
Thank you, Jan. So we have two speakers today talking about project delivery methods, options, and recommendations for two projects we have coming up. The next projects in our master plan build-out, which is what is sometimes called the Phase 2 or the critical care / emergency department building, and the parking garage. The parking garage, as you might recall, is directly behind the central plant project, which was just recently completed this year in May, occupied in May, and the Center for Joint Replacement, which was occupied in June of this year. And so these next projects are for the parking garage, and then the critical care building. That is the next major portion of the master plan build-out. And so to present to you these options today are Eric Fersman, and to provide a little information about the market is Ray Graves. Eric Fersman is a senior principal with Wolfberg, Rees, Kolvig, and Fersman. He has over 25 years of experience in negotiation, bidding, award, arbitration, mediation, and litigation matters arising from construction contracts of all types. Mr. Fersman's practice encompasses construction project planning and administration, construction litigation, and trials. He has a Bachelor of Arts from the University of California, Los Angeles, and a JD from the University of California, Hastings College of Law. He's appointed to the Northern California Super Lawyers in Construction Litigation in 2007, 2008, 2009, 2010, 2011, and 2012. He's lectured and given continuing education in bar programs regarding public works contracts for over 15 years. He's a fellow in the Litigation Council of America and a guest faculty at the School of Trial Advocacy at the Stanford Law School from 2007 to the present day. Ray Graves is a construction project manager with over 35 years of diverse experience. He's a licensed architect with a master's in management from the Stanford Sloan program. For 24 years, he was a project manager and executive building. He was a project manager and executive building and running construction management operations of up to 100 people for two national construction management firms. In '94, he founded Graves Associates, which provides a wide range of project management services. His project experience includes many project types, including hospitals and other healthcare projects. Mr. Graves' primary services are managing construction projects and multiple project construction programs on behalf of building owners, and he specializes in workouts of construction projects that have experienced delays, cost overruns, and disputes. And he has resolved many construction disputes, working with project owners and their legal counsel through negotiation, mediation, and arbitration, and has served as an expert construction witness. He has worked with Washington Hospital since 2007. And so without further ado, I'll have these two gentlemen go over the process that we would like to follow for the procuring of general contractors and bids for these two major projects coming up.
Thank you, Ray, and good evening. I'm Eric Firstman. I have appeared before this board before on several occasions. Most relevant here when we were putting together the bid package and the bidding methodology for the central plant and the Center for Joint Replacement, which is a method that we're going to recommend that the board consider again with a couple of changes. And we do want to go through the general options, the statutory framework, and the basis for our recommendations. As a lawyer, I do have to go over what is the law. And the law, we are a public entity. We're subject to the Health and Safety Code. We're required to competitively bid our construction contracts. There are exceptions for competitive negotiations for certain types of hospital districts in certain types of situations, but they will not apply on their face for a project or for projects of this size. If we are going to proceed to competitive negotiations, as we did to a limited extent with the central plant projects, we will need a waiver from the board. And I do want to talk about what we did before and what we are proposing to do here. The contracting options that we will review here today, primarily two: design bid build, or what is also referred to as low bid, and construction manager at risk, which is the second method that we will review and be recommending. Options that are used in the industry that we will not consider: one is design build. That is generally not used on OSHPD construction and is not an option here because we have a full set of plans and specifications. Another method is leaseback, but that is not available to hospital districts on projects of this size. It is primarily a financing mechanism. The third method is construction manager with multiple prime subcontractors, and that is just not appropriate for a job of this size. So the two methods that we have considered for these two projects are design bid build, or low bid, and construction management at risk. The design bid build methodology is well established. It is a methodology that works on many types of public works. It does have a bad reputation. It is not used on OSHPD construction, but it is a methodology that generally works, but not on projects the size of these projects where we have OSHPD oversight. The advantages: it is established, it is clearly within the statute. Design bid build will usually result in a lower price initially on bid day than construction management at risk. Disadvantages: one, it's not used on OSHPD jobs. As the board may recall, when we sought to competitively bid low bid the central utility plant, the first time we got no bidders, the second time we got one bidder. And we can talk about those reasons. This method is likely to discourage contractors from bidding that have the specialized expertise in OSHPD construction. This method is one where the general contractor will submit their bid with their subcontractors. There's no selection of subcontractors, and they will only bid what's shown in the plans and specifications. That's it. Anything that's left out, anything that's wrong, is the basis for a change order. We have here a graphic of the design bid build methodology, and if I can get this to work, you can see the hospital is in contract with the contractor. Contractor submits a bid with their subcontractors in tow. The hospital would have no opportunity to review, pre-qualify, or address individual issues with subcontractors. Very common methodology, but not on OSHPD construction. And I'll step back for one moment and say that OSHPD construction, particularly OSHPD 1 construction like this hospital, are very unique construction projects. They require very specialized expertise. They require contractors with significant experience in hospitals, significant experience in working with OSHPD, significant experience in the process. Nothing substitutes for experience in hospital construction. The second method that we are recommending and that is used in hospital construction is referred to as construction manager at risk. And as the board knows from our prior work on the central utility plants, our firm does have a significant practice in setting up projects. And I can state from personal experience in the last 4 years, setting up maybe 10 hospital projects. None of the projects were let on design, bid, build, low bid. I can think of at least 8 that were awarded using the construction manager at risk method or a variation of that. This is the method that's used in the industry for these types of specialized projects. 3 basic steps. First step, hire the construction manager. And you just hire the individual construction manager. Usually you pre-qualify the firms, then you'll select the firms from the pre-qualified firms, either on their proposed prices for pre-construction services and markups only, or a combination of their prices and their qualifications. One method where it's just on price is pure competitive bidding. Another method where you consider their qualifications, you can consider that a form of competitive negotiations. Construction management at risk is a process. Essentially, 3 steps. As I just mentioned, the first step, the construction manager is engaged based on proposals. They're pre-qualified first, and the qualification standards are high. So there's not a lot of firms that will have the expertise and the experience and the track record to be able to be the construction manager at risk on a project or on projects of the size that we are working with here. From those firms, we receive proposals. Select the firm, the winning firm, on one of 2 grounds, either solely objective criteria, which will be pricing and perhaps a scoring of qualifications, although that's tough. But it can be pricing, or mixed, pricing and qualifications. Mixed, we'll get to, requires a limited waiver of competitive bidding. Step 1, we hire the construction manager. Step 2, the construction manager will review the designs. Designs are finished. Construction manager will review them as a contractor for issues with constructability, coordination, all of the types of issues that result in change orders for errors and omissions on the constructability side during construction. And they get a fee, and they're responsible to review the drawings. The drawings are reviewed and corrected, and the constructability issues are addressed. The construction manager will develop the bid packages for the trade subcontractors, but the hospital will conduct the bidding. So all of the trade subcontractors, either all or substantially all of the actual construction work, bricks and mortars on site, will be competitively bid by the hospital. in compliance with the competitive bidding laws. This gives the hospital control over the subcontractors, over pre-qualification, over their scope. If a subcontract package should come in and something is wrong, they can rebid it. Very different from design, bid, build. Then, step 3, the subcontractors are assigned to the construction manager at risk, who then takes that subcontractor or takes those subcontractors as its subcontractors, and is essentially, you're in the same format, same protocols as you would be with a low bid contractor. However, you have a couple of significant differences. The first is that the trade contractors are not selected by the contractor and brought to the table as part of a bid on a take it or leave it basis. 2, if there are problems in any particular trade contract, before it's assigned to the construction manager, hospital can fix it or rebid it. 3, because the construction manager has had the opportunity to review the plans and specifications, the construction manager then has responsibility for errors and omissions in the plans that may go to constructability issues that they could have prevented. There's a contingency of 3% to cover those issues because contractors aren't perfect. But anything over that, the contractor's at risk. And anything that they don't spend, then the savings is shared. So although the orientation is very similar to design, bid, build, the incentives with respect to errors and omissions in the plans and specifications are reversed. Whereas low bid, the incentive is anything that's not in the plans and specifications is a change order. And those are the rules of the road, and that's the way it works. With construction management at risk, their job is to get in there early and find all of those issues, because if they come up in construction, the construction manager's at risk. They have a very limited change order right. So the roles are reversed, the incentives are reversed. This is a way for owners to bring in the expertise of the contractor. This is the way for contractors to manage their risk of price and really move the responsibility for construction and completion of the plans and specifications and completion of the work to their subcontractors, manage the work much more carefully. And this is a very common method on OSHPD construction. Now, there are some legal issues with respect to this methodology. And before we get there, one of the things that I did say is that this method, it takes a little bit longer. There are a number of transactions involved. It's a process. It's not, you open bids, you've got a contractor, away you go. This is a process. But this is a process that is standard in the industry for hospitals. Legal issues for construction management at risk, before I turn this over to Ray, is for construction management at risk, if the construction manager is selected solely on the basis of the construction manager who proposes the lowest fees and markups and overhead, then that complies with competitive bidding, because the construction manager is selected, pure competitive bidding. The subcontractors are selected, pure competitive bidding. You combine the two, and everything is fine. There were some practices where the CM would bid the trades and negotiate negotiate a price, and the California Supreme Court said that is not compliant with competitive bidding. So what we are proposing here is that we go forward initially and competitively bid, or seek to competitively bid both steps. If the trades, or if the contractors, if we do not get as competitive a bid field as we want, then we may come back to the board and ask for a limited waiver to consider qualifications in the selection of the construction manager, but no other changes. So all of the construction work on the ground would still be competitively bid. So you'd have vast majority of the work competitively bid, the construction manager selected on a combination of price and qualifications. And this process of selecting the construction manager on price and qualifications is what we ended up doing on the central plant projects. It worked out well. So we do have a precedent for that. We're not asking for that authority here this evening. We're just, as we go forward, if we get the authority to advertise that we're asking for, and if the bid field that we get is such that the bidders, we won't get enough unless we consider a qualifications element, then we'll come back and ask. And with that, I'd like to turn this over to Ray Graves to talk about the advantages of this methodology. Thank you.
Eric has talked about the legal issues and the framework in which we work to comply with the laws and regulations. I'd like to address some of the business issues and the more practical concerns of a project manager like myself. First, what are the real advantages or benefits of using this approach? First of all, this is the predominant technique used in private industry. Most private projects are done this way. And usually a private owner will set up a team, and that team will keep rolling through projects so long as they're performing properly. And I've worked with a number of teams in doing those kind of projects. Secondly, as Eric has indicated, it is the predominant method for doing large construction of hospital projects. Not that we don't do smaller projects to a pre-qualified low bid general list on smaller jobs here and at most other hospitals, but it is there are very few large jobs, that is over, say, 100 million, that would even attempt to do a public bid because it won't be successful. The benefits of this approach are that it considers not only price but also qualifications. And by doing that, we're more likely to retain both the firms and the individuals. That's the key to the teamwork, are the individuals. We're more likely to retain those that are quality firms and can get the results that we're looking for. It encourages teamwork in a number of ways. It encourages them by aligning the interest of the team members with the owner and with the project goals, and it does that explicitly in the agreement through a number of techniques. Secondly, it encourages teamwork because when you're selected on qualifications, you darn well better do a good job on the project you're on if you expect to get the next job. Finally, it encourages the teamwork by the fact that it brings the contractor on board and into the process early, and they begin working as a member of the team, not coming in late to criticize the documents and find reasons for change orders in the documents. The pre-construction involvement of the contractor is probably the key part of that makes this technique work. That is, we're bringing the contractor into the team as a team member. We're bringing them in with their expertise and tools to achieve things that only they can achieve as a contractor. And that would include the constructability review we've talked about, and along with that, probably some value engineering to improve value and cut cost. It's also getting their involvement in scheduling and cost estimating, which is their real forte as a contractor. and it's making sure that we're packaging the bids so that we can get the best competitive bids from subcontractors. And to some degree, the subcontractors are really going to bid because of the particular CMGC that they would be working with and their past relationships with them. We did, in preparation for this selection process, we did do a market survey. We essentially talked to the same firms that we talked to in early 2008 when we selected the CMGC for the CUP and CJR projects. We went back to those firms and asked them several questions about their interest in the project, about their availability, and about other projects that might compete with our project for construction resources. There are about 20 projects that are on this list that came out of that process. Those highlighted, I think there's 10 of those beside our project on the bottom, will be going concurrently during the same time period from 2012 to, say, 2018, and therefore will be to some extent competing with us for the resources. As you can see, a number of these show to be named as far as the CMGC. So the point is that we will be competing with quite a number of other projects, and probably some that we've not yet identified or we don't know about yet. That list totals $4 billion in construction just in hospitals. We also ask about other projects that might compete with us, especially local projects. And this list contains another $6 billion. You'll see that 3 of these are fairly local here in Silicon Valley, the 49er Stadium and the 2 projects in Apple and Google. This is by no means meant to be a comprehensive list of all the projects that are out there. This is just to highlight a few of the very big projects that use copper wire and reinforcing steel and concrete, just like our project does, that we'll have to be competing with. The point of this is that this is together, just these projects together, about $10 billion. And there are probably no more than 8 qualified CMGC firms to do a hospital like we're talking about doing. 6 of those we would probably consider to be qualified by previous experience. And some of those firms are not going to be interested or available for our project. So we're going to be talking about narrowing down the list to less than 6 firms. And so I think the point of the research on the projects here is that we're in competition with other hospitals for construction resources. And we're going to want to select the best firm that we can for our project. So this selection process will be very critical to the first step in that process. Secondly, we're coming out of a recession. Most contractors have downsized during the recession, and if and when the long-awaited recovery happens, they're going to have to staff back up again to get back to size. And the real question will be how fast these projects come into the market and are able to be absorbed by the market. And that's going to affect us in at least a couple of ways. It's going to affect us in the procurement of materials and equipment and so forth. That is the lead times and the scarcity. And that is going to indirectly affect us in the law of supply and demand, affecting the inflation rate and the escalation rate in construction. So those are the issues that we'll be looking at closely and trying to, though we cannot manage them, we're going to try to at least anticipate that they're there and deal with them as we can going forward. I'm going to turn it back to Eric at this point to wrap up with recommendations and closing.
Thank you, Ray. So the recommendations that we are making to the board here this evening is that the project team, the hospital, be authorized to advertise for statements of qualifications from interested firms, to start with a bid package and a contract package that will conduct that initial step that we talked about, the procurement of the construction manager, based on price, on objective criteria. And if we can get enough bidders that way, then that's how we'll do it. If we cannot, then we will come back to this board and request authority for a limited, very limited waiver of competitive bidding solely to include the qualifications element in the construction manager or in the procurement of the construction manager. And if that becomes necessary, then we will come back to the board and ask for that waiver specifically. As Ray has stated, and as we have noticed in the law firm, the Bay Area is coming out of a construction recession. The Bay Area has essentially a construction boom that is limited to the Bay Area at the moment. Other parts of the country do not have a construction boom, although housing is picking up and builders across the country are finding that they do not have the qualified subs or carpenters available because people haven't worked in 4 or 5 years, they've gone on to other jobs. How the dynamic plays out, how the market plays out, what happens in the next year or 2 or 3, if I had a crystal ball, I could tell you, but I'd be retired. But that's what we see. The industry is picking up. The volume is significantly picking up. We know that the trades are coming in from out of the area. The union halls are fairly stretched right now. So we will need to respond to a dynamic marketplace. The construction manager at risk methodology is the best way to do that. And whether we need to come back and ask for a waiver, we'll see how the market, we'll see what the bidders and the market does in response to the statement of qualifications. But for this evening, the only authority that we want is to advertise and to start the process that is in strict compliance with competitive bidding. Thank you.
Okay, so to be clear, there's no action that needs to be taken by the board tonight because we will just move forward as we have on all other projects, given under the assumptions that we've laid out here today. It's still a competitive bidding situation, and we would move forward with that, barring any concerns or objections from the board. We'd move forward with that without action. If there is an issue with the competitive bidding, as Eric laid out, we would come back and ask for action that you would waive the competitive bidding portions and we'd go into competitive negotiations. So with that, can I take any questions, or can the team take any questions?
First of all, I want to thank you, Ed and Eric and Ray. It was very, very, very good presentation, and I think that it really kind of lays out perfectly well for ourselves and for the members of our community what the options are that we're going to have to consider and what we're facing, and it seems fairly clear. And I also want to thank you for the work that you've done to date in helping us build our buildings, and you've done just the team that you've put together, Ed, is just an excellent team, and we're very fortunate to have you folks assisting us in the big task that we have in front of us to build the hospital of the future. So thank you very much. Members, would you have any questions? Bill?
Yeah, I've got a couple of questions, probably directed at Eric. First of all, you mentioned that most of the projects are using construction manager at risk methodology, but there are a few variations. Perhaps you could describe what those variations might be, and would any of those variations be applicable in our situation?
Sure. I believe the question is, what are the variations on the methodology that we see, and would they be applicable here? So I would say there's the primary variation that we see on this methodology is the nature of the subcontracts that are bid. We've worked on a number of hospital projects where the interior trades of the hospital, the mechanical, electrical, plumbing, drywall, the framing is bid to the trades not on lump sum subcontracts, but using a target cost approach. That is cost reimbursable with a fixed fee, fixed general conditions, and the subcontractors either make money or not. They make profit or they don't make any profit at all, but they're not at risk for the cost of construction, depending on whether they complete the job within the target cost and within the schedule. And the objective of that type of methodology with subcontractors is to incentivize them to aggressively respond to changes, which are very common on OSHPD construction, more so than other types of projects, and that is an understatement. But to incentivize the subcontractors to aggressively respond to changes in a proactive way to minimize time and expense. And that is a method that we've seen on a number of projects, and it works. That would be a very difficult method to use on a public works project. For public works, we do need to have a fixed price. We could put together a hybrid of a time and materials type contract, but that would be difficult. And that was not something that we wanted to recommend here. But that would be the primary change that we see. And then we see a number of variations of that approach.
Thank you.
So,
The second question I have has to do with why would you not proceed with using both objective and subjective criteria initially when you go out for bids and and get the waiver? And a corollary to the waiver question is there any liability that we incur or subject ourselves to potential litigation by requesting or by granting a waiver or going through the waiver process?
So I believe the questions are, why wouldn't we do a waiver initially? And if we do a waiver, is there exposure? Is there liability? So I think I'll answer that in reverse order. So anytime a public entity does not competitively bid a public works contract in compliance with the statutes, there is the potential of litigation from another bidder, from a member of the public, that the action was not in compliance with law. And so competitive bidding is something we want to comply with strictly, and it really puts the contractors at risk, because if they proceed on a contract that was awarded in violation of the competitive bidding laws and the court finds that, they could have to disgorge whatever they were paid and leave their work in place. And the case law on that is draconian and has been resurrected a couple of times over the last 150 some odd years since the first case came down. So it is the competitive bidding laws. There are a number of reasons for them. They're followed strictly. However, if competitive bidding does not work in the public interest, or if competitive bidding is, I think the courts call it, it's unavailing, or it is not going to work in that situation, then if there's evidence of that before the board can authorize a waiver of bidding. And it is for this reason that, first, the methodology that we have set forth, 99% of the work is competitively bid, or 95, whatever the percentage is. But the work on site, the bricks and mortar, the construction work is competitively bid per the public contracting laws. It is that little element of procuring the construction manager. And that's not a little element, but it is price-wise, it's not the same as the cost of building the project. Before we proceed to procure the construction manager on any basis other than competitive bid price, we want to go out to the market first and see if we're going to have the same type of reaction that we had when we went out for the central utility plants. And it's just a matter of being conservative and basing any finding of the board on relevant, current evidence from 2012. And I could say empirically, based on the last project, empirically based on experience, I'm sure that this is what is going to happen. But as a lawyer, it would be my preference that we base any finding on actual empirical data from 2012.
Thank you. That makes it
Okay.
very clear.
Thank you. Any other questions from board members? All right, well, Ed, thank you. Thank you, Ed, thank you, Eric, thank you, Ray, thank you very much. Okay, Jan, we're going to move on then to consider the minutes of the August 6th, 8th, 15th, 20th, 22nd, and 27th. A pretty busy month there in
A lot
August.
of meetings.
A lot of meetings, so may I have a motion for approval of
So
those minutes?
moved.
Second.
Okay, all those in favor?
Aye.
Opposed, motion passes. Any oral communications tonight? All right, then, we're going to move to the written communications and Dr. Romano. Good evening.
Thank you, Mr. Wallace. I'd like to present the medical staff credentials committee action items for August. First will be the appointments. They are Dr. Koa Nguyen, internal medicine, to provisional active. Dr. Doust Sarpel, infectious disease, to provisional courtesy. Dr. Brian Baduch, cardiothoracic surgery, provisional active. Fritz Baumgartner, cardiothoracic surgery, provisional courtesy. And Sarah Prosperseed, ophthalmology, provisional active. The reappointments for the month are Drs. Ramsey or Raj in surgery, active. Koban, physical medicine rehabilitation, active. Stephen Bardis, podiatry, active. Joseph Callahan, anesthesia, active. Linda Chan, pediatrics, active. Lawrence Crane, internal medicine, active. Teginder Danoa, family medicine, active. Susan Degoni, pediatrics, active. David Freiheit, emergency medicine, active. Apolinar Gakote, internal medicine, active. Ali Halashpour, pediatrics, active. Benjamin Halligan, orthopedics, active. Jill Harrell, orthopedics, active. John Heine, urology, active. Mary Hu, gastroenterology, active. Adil Arani, cardiology, active. John Jaragito, orthopedics, active. Nitin Joshi, hematology medicine, active. Prabhat Khalsa, neurology, active. Amanda Lee, internal medicine, active. Sohail Matamed, orthopedics, active. Dushyant Oza, neonatology, active. Sudipti Prasad, OBGYN, active. Gautam Parikh, internal medicine, active. Nicole Rimple, internal medicine, active. Ahmed Sadek, hematology medicine, active. Seema Sharma, family medicine, active. Stephen Siegel, orthopedics, provisional active. And Peter Silvera, orthopedics, active. Next page, William Stearns, orthopedics, active. Dr. Evan Strong, nephrology, active. Sujata Tipnis, pediatrics, active. And Frank Zaidan, emergency medicine, active. We'd like to grant reappointment from October 1st, 2012 through March 31, 2013 for Martin Cass, maintaining the conditional reappointment for his FPPE. We would like to recommend that you grant full reappointment from October 1st, 2012 through September 30th of 2014 for Dr. Rajesh Suri. The probation as a medical board action has been completed in a satisfactory fashion. We would like to discontinue proctorship and advance the following physicians: Arkana Bindra in endocrinology to active staff, Sanjay Bindra, cardiology to active, Crystal Evie, internal medicine to active, and Ryan O'Connor, emergency medicine to active. We would like to recommend advancement to ambulatory staff from the provisional ambulatory staff for Kai Uye in pediatrics. And we would like to recommend discontinuing proctorship for Terrence Lynn in cardiology for the special privileges delineated, moderate sedation, transesophageal echocardiography, ICD implantation, percutaneous transluminal angioplasty, cardiac catheterization, and percutaneous cardiac intervention, or percutaneous coronary intervention. And for Dr. Kilaru, hyperbaric medicine. On page 3, we'd like to recommend discontinuing proctorship and advancing staff status for Dr. Stephen Siegel, orthopedic hospitalist from provisional to active, and Kate Wong, physician assistant from Allied Health, provisional to Allied Health. We would like to recommend, I'm happy to say, reinstatement from a leave of absence for Dr. David Burke to the ambulatory category. And finally, we have 2 resignations, Mohammed Nazari and Christy Lear, physician assistant.
Thank you, Dr. Romano. May I have a motion for approval of the medical staff credentialing action items, please?
So moved.
We have a motion.
Second.
Thank you. Any questions? All right. All those in favor? Aye.
Aye.
Opposed? Motion passes. Hello, Sharon. Hi. The Service League report.
Okay. Well, as you just heard earlier, in a few years, Phase 2 of the district's master plan will include the completion of the Morris Hyman Critical Care Pavilion. So since it's full speed ahead on construction, we at the Service League also need to have long-range plans as to the growth and service of our members for the betterment of the community and the hospital. We are actively looking to increase our membership of adults to fully service all of our existing positions. The Service League is reaching out to the greater community and asking if you're looking for something rewarding and fun, why don't you consider volunteering at the hospital? We have monthly information sessions that will explain everything we do here. Please see the hospital's website, whhs.org, for more information. We will also be meeting with the Service League past presidents in the near future to discuss new and innovative ways to encourage our existing members to step up to our leadership roles. This is to also meet the hospital's long-term goals. We've started interviewing new adult members who have begun so that we can find out more about the new volunteer and they about us. We want to make sure they feel the area they choose to volunteer in is a good fit for them. We also want to see what talents and experience they can bring to the league. Our future newsletters will include an article from the managers of the gift shop to help promote service interest and sales. Lastly, I'd like to share that at our recent safety fair, we surveyed all of our volunteers who came through to see how we are doing and to see how we can better serve the hospital. We found out that our students are full of energy and want to give back more. Now we just have to figure out how to best use their talents. Our survey questions included quality of our training, our logistics system, and their overall experience and satisfaction as volunteers. Thank you.
Thank you, Sharon. Any questions? Thank you very much. Okay, Dr. Romano, back to you.
Okay, I have the medical staff report for September 1st, 2012. If you look on the first page, you'll find we have a grand total of 532 members. This includes 515 in the medical staff and 17 in allied health. And in the medical staff, there are 365 members who are active and 37 who are provisionally active, which brings us for the first time in my report over 402 active physicians. On the next page, you'll see a little review of the 5 new members that were approved tonight. And then on the last 2 pages, you'll see a summary of the applications. And you'll notice we have 11 pre-applications in process from a variety of specialties. And we have 21 applications in process Of those 21, 4 are from East Bay Cardiovascular and Thoracic Associates. 11 are applying for admission to active staff, 5 to courtesy, and 5 to ambulatory.
Thank you, Dr. Romano. Any questions? Okay, Jan, we're going to move to
We're going to do the calendar.
the calendar.
Put it up and watch.
Past health promotions and outreach events. On August 2nd and 9th, the City of Fremont Summer Concert Series continued. As the presenting sponsor for this 6-week series, representatives from Washington Hospital and Washington Township Medical Foundation provided blood pressure screenings and blood glucose screenings, along with general health information. Dr. Jacob Epen and Patricia Danielson, Washington Township Healthcare District Board members, along with Dr. Ash Jain, cardiologist, and Dr. William Degoni, general surgeon, spoke during intermission. The speakers highlighted programs and services at Washington Hospital, featured some of the awards received by the hospital, and provided an overview of the plans to build a new state-of-the-art modern emergency department and critical care pavilion to meet the community's growing needs. 91 screenings were provided, including 38 blood pressure and 53 blood glucose screenings. The City of Fremont estimates that approximately 3,000 people attended the concerts in August. On August 2nd, as part of the Diabetes Matters series, Christy Caracappa presented Getting the Most Out of Your Insurance When You Have Diabetes. 18 people attended. On August 7th, as part of the Stroke Education series, Dr. Ash Jain and Doug Van Houten, RN, presented Acute Management of Stroke, Chronic Care and Stroke Rehabilitation. 7 people attended. On August 11th and 12th, the American Cancer Society hosted the Relay for Life event at Newark Memorial High School. This 24-hour walkathon raised money and awareness to save lives from cancer. Washington Hospital was a major sponsor of the event, given our focus on providing a wide range of cancer services to our community. The American Cancer Society reports that over 300 people attended. On August 14th, Dr. Kadir Halimi, Emergency Medicine, and Brenda Brennan, RN, Clinical Nurse Specialist, presented Learn the Signs and Symptoms of Sepsis. They discussed the severity, prevention, and early signs of the life-threatening bacterial infection sepsis. Katie Choi, RN, Clinical Nurse Specialist, served as moderator for this program. 49 people attended. On August 21st, Dr. Bruce Nixon, radiologist, Radiation Safety Officer, presented Radiation Safety: What You Need to Know. The presentation focused on radiation exposure and precautions that are put in place for patient safety. 19 people attended. On August 21st, Ellen Kuzo, RN, certified hospice and palliative nurse, assisted individuals and families in filling out advanced directive and POLST forms. POLST stands for Physician Orders for Life-Sustaining Treatment. 8 people attended. On August 25th and 26th, the American Cancer Society hosted the Relay for Life event at James Logan High School in Union City. This was the third and final Relay for Life in the Tri-City area this year. Washington Hospital was a major sponsor for all 3 Relay for Life events, taking place in Fremont, Newark, and Union City. The American Cancer Society reports that over 500 people attended. On August 27th, the Washington Women's Center presented Yoga and Coping with Chronic Pain. The presentation focused on ways to relieve pain and improve quality of life by utilizing physical activity and nutrition. Bonnie Mehta, RN, certified yoga instructor, led the session. 8 people attended. On August 28th, Dr. Mary Maish, thoracic and foregut surgeon, presented gastroesophageal reflux disease, or GERD, and your risk of esophageal cancer. What can I do? This event was co-sponsored by Washington Township Medical Foundation. 65 people attended. On August 29th, the City of Fremont Human Services Department and members of the Tri-City Elder Coalition hosted the Four Seasons of Health Expo, Engage Health. Washington Hospital staff participated in this event by promoting Washington Hospital services and providing health and wellness information. 62 osteoporosis screenings were provided. The City of Fremont Human Services Department reports over 800 people attended the event. As part of the Washington Women's Center Lunch and Learn program, on September 4th, Dr. Vandana Sharma, oncologist, and Nikki Chun, certified genetic counselor, presented Cancer in the Family, Am I at Risk? 22 people attended. On September 4th, as part of the Stroke Education Series, Doug Van Houten, RN, presented Stroke Prevention and Other Disease Processes, Healthy Lifestyle, Be Smart and Avoid Stroke. 11 people attended. On September 6th, as part of the Diabetes Matters series, Vida Reed, RN, and Sandra Mertisdorf, RN, presented Diabetes Control, Back to the Basic Keys for Success. 44 people attended. Upcoming health promotions and community outreach events. On September 18th, from 1 p.m. to 3 p.m., Dr. Sandeep Gupta will present Osteoarthritis, What You Need to Know. This event is co-sponsored by Washington Township Medical Foundation and Washington Senior Care. On September 18th, from 3 p.m. to 5 p.m., Ellen Kuzo, RN, will be available to assist individuals and families in filling out the Advance Directive and POLST forms. POLST stands for Physician Orders for Life-Sustaining Treatment. Registration is available for 30-minute appointments. Walk-ins are welcome. The City of Newark is holding its annual Newark Days Country Jamboree from September 20th to 23rd. The event includes a parade, the Newark Mile Race, a carnival, a car show, plus food and game booths, music, and much more. Washington Hospital Healthcare System is a major sponsor for this event. Washington Township Medical Foundation will be participating in the information fair taking place on Sunday, September 23rd. On September 25th, from 1 p.m. to 2:30 p.m., Kimberly Alvari, registered dietitian, will present Dietary Treatment for Celiac Disease. Learn about gluten sensitivity. As part of the Washington Women's Center Lunch and Learn program, on September 27th, from noon to 1 p.m., Dr. Vandana Sharma, oncologist, will present Early Detection and Prevention of Female Cancers. On September 29th, from 7 a.m. to 12 noon, the HERS Breast Cancer Foundation will hold its 13th annual Keep Abreast Walk Run Community Resources Health Expo. The Washington Hospital Healthcare Foundation Report. Join the Washington Hospital Healthcare Foundation for the 26th annual Top Hat celebration under the Grand Tent. Co-chairs for the event are Dr. Sandeep and Purvi Kunwar. Proceeds from the 26th annual Top Hat Gala have been designated to support construction of the Washington Hospital's second operating room of the future. Funds will underwrite the purchase of Brain Suite, a high-tech imaging system that helps surgeons to operate with precision on the brain and spine. Sponsorship opportunities for this event are available now. Washington Hospital Employee Association, WIA. The 2012 Don Pickenpaw WIA $2,000 scholarship was awarded to Julia Solano. Julia is the daughter of Yulina Solano, a clinical lab scientist at Washington Hospital. Julia graduated from Leadership Public Schools in Hayward and will be attending UC Berkeley to pursue engineering and the arts. From July 23rd through August 17th, WIA held its annual back-to-school supply drive. A total of 105 backpacks full of school supplies were collected. The backpacks and supplies were donated to SAVE, Safe Alternatives to Violent Environments, and Abode Services. In addition to the backpacks, WIA received $360, which was used to purchase gift cards from Target to allow families to purchase school supplies as needed. During the Fremont Festival of the Arts on August 4th and 5th, WIA sold Washington West parking spaces for $5 each. The fundraiser earned $6,500. Dwight Williams, Supervisor, Safety and Security, led the project with the assistance of Washington Hospital volunteers. On August 18th and 26th, WIA held Family Fun Days at Roaring Camp in Felton. Roaring Camp, located in the Santa Cruz Mountains, is a recreation of an 1880s logging town. Employees and their families enjoyed a barbecue lunch, riding on an authentic 1880s steam locomotive through the California redwoods, volleyball, horseshoes, and shopping at the general store. Approximately 200 hospital employees, friends, and family members participated in the outings. The Washington Township Healthcare District Board of Directors report. During the month of August, District Board of Directors represented the district at the following events. Dr. Jacob Epen and Patricia Danielson represented the district at the City of Fremont's Summer Concert Series in August. Patricia Danielson represented the district at the Washington Hospital Employee Association's Family Fun Days at Roaring Camp in Felton on August 18th. Patricia Danielson represented the district at the Four Seasons of Health Expo Engage Health, which was put on by the City of Fremont Human Services Department and the Tri-City Elder Coalition. The event took place on August 29th in Fremont. Washington on Wheels, WOW, Mobile Health Clinic. During the month of August, the Washington on Wheels Mobile Health Clinic, also known as WOW, provided physical exams and immunizations for students heading back to school and children entering kindergarten. In addition, WOW provided healthcare services to community members at the Fremont Senior Center, Fremont Family Resource Center, Silliman Activity Center in Newark, Regary Senior Center in Union City, and the New Haven Adult School, also in Union City. WOW concluded the free summer glucose screening outreach program in August. These screenings were provided at all of the community locations visited by WOW, as well as the summer concert series in Fremont Central Park. During the month of August, 115 people were screened, bringing the total number of people screened this summer to 394 people. Community contribution. In August, Washington Hospital Healthcare System donated 40 cases of assorted dry food to the Alameda County Community Food Bank. The donated food helps the food bank alleviate hunger by providing nutritious food to people in need. Through its network of 275 member agencies, the Alameda County Community Food Bank distributes food to food pantries, soup kitchens, child care centers, senior centers, after-school programs, and other community-based organizations. Food for 300,000 meals is donated throughout Alameda County weekly by the food bank. The food donated by Washington Hospital is valued at $3,700. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was August's most viewed webpage with 15,932 views. Other active sections include InHealth, Channel 78, Washington Hospital's Cable Channel 78 aired a number of new programs this month. For more information on any of the programs mentioned, visit www.whhs.com or call 1-800-963-7070.
Okay.
I would like to
Jan,
introduce
please.
you to the Employee of the Month.
Yeah.
I think, do you have a picture for us, Joe? Okay. This is Lisa McGinty. She has been at the hospital since July of 2009, and she's the Major Gifts Officer for Washington Hospital. In her role, she's successfully cultivated and solicited dozens of donors who have given gifts to the hospital. Before coming to the hospital, she was living in Missouri. She earned a master's degree in public administration from St. Louis University and a bachelor's degree in American Studies from the University of Notre Dame. At work, Lisa is considered to be a very professional and warm person, and a lot of the donors say about her she has a tremendous ability and they frequently comment on her warmth and professionalism. She lives in Livermore and with her husband and her 3 young children.
What department is she with?
And she's in
Foundation.
Oh, the foundation.
yeah.
Okay.
She's with Angus.
Oh, okay. Good job, Angus. Okay, we are now going to move into the to the quality report with Stephanie. Good evening, Stephanie.
Good evening. Tonight I'm going to be presenting the Quality and Patient Safety Dashboard for quarter ending June 2012. As usual, we have the definitions in terms of what we go by. At first, let's take a look at all of the patient safety goals. The first one is the handoff communication. This is when you hand off over the patient condition from one caregiver to the next, and we met goal. The second is the procedure timeout. This is making sure the right procedure is done at on the right patient at the right time. And again, we were at 100%. Patient safety falls with moderate injury. For quarter ending June, we had no falls that had moderate or any kind of injury. We have an aggressive fall program, and we do post-fall huddles. We have the 4 Ps, which is the potty and checking the patients to make sure that if they have to go to the bathroom and the toileting and the turning and all of that, that goes along with it. In terms of the sepsis mortality, this goal is about to be changed. The Surviving Sepsis campaign has come out with new guidelines. The sepsis team under Dr. Halimi and Dr. Aquilili leaderships are now reviewing the guidelines, and we will be seeing, hearing more about that in the weeks to come. In terms of looking at our pressure ulcers for quarter ending June, we had none. Again, this is a prevalent study. You take 1 day in a quarter and you look at every patient in the hospital and you turn them to see whether there's any sign of breakdown. And again, we met the goal for that quarter in terms of 0. Looking at our MRSA infection rate, and this does not include the surgical site infection, but this is looking at hospital-acquired MRSA. And for the quarter ending June, we had 0. We continue to be very proud of our VAP, which is our ventilator-associated pneumonia rate. We have gone 931 days without a VAP infection. The last time we had one was December of 2009. So we are very proud. This is usually the ICU team working together to make sure that we provide safe care for the patients. The C. difficile hospital-acquired, again, this is a bacterial infection. We have a team that looks at this on a quarterly basis. Again, we are beginning to do education in terms of the community and nursing homes because this is something that's related to antibiotic usage. We're also looking to see if there's any cross-contamination. So there's an active group that's looking at this on a regular basis. Tonight I'm going to focus on the critical care as it relates to urinary tract infection and also as it relates to the central line infection. Urinary tract infection for quarter ending June, we had none in critical care. They have a performance improvement team that's multidisciplinary, that consists of the nurses and the multidisciplinary team. And this is one of the projects they have taken on in terms of trying to prevent urinary tract infections. And for the quarter ending June, there weren't any. The same is true for the central line associated bloodstream infection. For a while there was a blitz in critical care. Again, the nurses got together. They have a multidisciplinary team that's involved. They have done education. They have looked at their processes in terms of how they can change it. They have looked at their hand hygiene. And again, for quarter ending June, we have had none. And that's a huge accomplishment from where we were from previous quarters. Moving on to the core measures. If you go to Hospital Compare website, this was last refreshed on July 19th of this year. And again, it's a rolling 4 quarters. But for us, I'm going to focus on the quarter ending June, but yet you're going to see the latest information that's on the website should you go there. For the acute MI, prevention of heart attack, I want to focus on the primary PCI. We 92% of the time the patient got to the cath lab. There were 2 incidents that was system issue. One, there was another patient on the table, and the other one was the patient came in, went up to the floor, extended the MI, and then was taken to the cath lab. And you know, it was not one of those that was a STEMI on admission. But we continue to have a team that's looking at that and very aggressive in terms of making sure those patients get to the cath lab within 90 minutes to open the vessel. Looking at heart failure. Heart failure is one of the core measures that's very discharge loaded at the end of the patient stay. All discharge instructions, we continue to work on that. We were 94.6%. There was some issues in terms of computer glitches. I think we are on our way in terms of solving those, and hopefully we should see an improvement in that score. But then again, we still compare to both the state and national average as a benchmark. Core measure for pneumonia, we were 100% in terms of the blood culture. And in terms of initial antibiotic selection, we were 94% for the quarter ending June. The physicians may have a good reason of why they gave a different antibiotic, but that reason must be documented. So if it's not documented, there's not credit that's given for the antibiotic selection. Moving on to SCIP, I want to highlight antibiotics within 1 hour of incision. We met the goal 98.8% of the time. Again, there was one patient that got the antibiotics a little over an hour. And we continue to work to solve some of these system issues that may appear. But in terms of appropriate antibiotic selections, we were 100%. For HOP, which is our outpatient surgical procedures, the antibiotic timing, we were 97.6% for the quarter ending June. And again, it's that timing. They have to get that antibiotic within an hour. It's not an hour and 1 minute. It has to be an hour, and oftentimes it's slightly over an hour. So if not, we are looking to see, making sure it's part of the timeout so that we get it within an hour. And the same is true for the antibiotic selection. It may be the right antibiotic to give for that patient particular condition, but it must be documented in terms of getting credit. And that's about it. Any questions?
Thank you, Stephanie. Any questions? Okay, thank you. Thank you very much. So now we're going to go to Chris Henry and the finance report. Hi, Chris. Good evening.
Okay, so tonight I will also be presenting the August hospital operations report on behalf of Ms. Farber. So, Mr. Wallace, with your permission, I'll just move right into it when I finish up with July. Okay. But first we'll look at July. Average daily census for July landed at 154.6, about 29.5 below the budget of 184.1. Admissions were 57 below budget at 1,000, and our patient days were 914 below budget at 4,794. Our average length of stay for the month came in at 4.94. We'd expected 5.4 in the budget. Looking at utilization, our case mix index for the month was actually higher than we've seen it for a while, landing at 1.451. We had 160 deliveries in the month. We had expected 173. Surgical cases came in 19 above budget at 379. That included joint replacement cases that were 6 above budget at 101. Neurosurgical cases were 5 above budget at 23. And our cardiac surgical cases were 6 above budget at 15. And those cases really driving that case mix index up. PTCA procedures for the month landed at 48. We had expected 56 for July. And our outpatient visits for the month were 139 above budget at 8,904. The emergency room saw 4,242 visits for the month, pretty close to the budget of 4,261. Moving into our productive FTEs. We had 1,259.2 productive FTEs in July. Non-productive FTEs landed at 227.9, giving us total FTEs 135.6 below budget at 1,487.1 as we tried to flex down for that lower activity in the month. Even with all that effort, our FTEs per AOB came in at 7.2. We'd expected 6.81 for July. Moving into the financials, and as always, we'll look at our Governmental Accounting Standards Board presentation. This is the presentation used for our audited financials. Total patient revenue for the month came in $5.4 million below the budget and $167,700,000. Our contractual write-offs for the month were a little bit higher than we expected at 76.51%. We had several unusually high dollar accounts hit in July, and the majority of those were Medicare and Medi-Cal, so it required some additional reserves to be booked. So we ended the month with net operating revenue about $2.4 million below the budget at $39,696,000. Operating expenses for July came in $1,621,000 below budget at $40,659,000. That variance largely being driven by our lower FTEs, so our salaries and wages were lower. We also had favorable variances with our supplies, with the lower number of patients in the house, and our purchase services as well. So we ended July with a operating bottom line from a GASB perspective and also FASB perspective with a loss of about $963,000. Non-operating income, however, came in about $1.9 million above budget at a little over $3.1 million. We did post a $339,000 realized gain on our investments and an unrealized gain on our investments of almost $1.5 million. So we end July with a total bottom line from a GASB perspective, a little bit more than $1.1 million above the budget at $2,170,000. Take a quick run through our Financial Accounting Standards Board presentation, and for those who aren't familiar with this is the way the financial markets tend to look at us. Our operating bottom line stays the same with a $963,000 loss. We pull out our unrealized gain on investments as well as our property tax revenue to come up with non-operating income from a FASB perspective, about $400,000 above the budget at $951,000, and a total bottom line showing almost break even, about a $12,000 loss for the month from GASB perspective. So are there any questions on July before I move into August?
No, I've read that it appears that throughout at least the Bay Area, that the hospital usage is down.
Yeah, we're hearing that from all our contacts with our neighboring hospitals, that volumes are down all over the area. And I think, as you said, a lot of that's showing up in the press, so.
Yeah. And you know, at one level you think, well, boy, that's a good thing because people aren't sick, but on the other hand, you know that they are just as sick as usual, and perhaps the benefits that they've had are
Yeah, and
being
it's
used
happening
up.
in a tough environment where we're getting pressure on our revenue from all the payers as well as having the operational pressure with the low census, so.
Yeah.
It makes it tough to operate, particularly when we need to flex down our FTEs. You know, we try like heck,
Yeah, I know in many ways it can be a guessing game about what you're going to do.
Yeah. Okay, so moving into August results. The month of August saw 975 patient admissions that resulted in 4,681 days of care. The average daily census for August was 151. This average daily census was lower compared to July's average daily census of 155. August's high and low census was 173 and 118 respectively, so that's pretty low for us. The budget for August anticipated 1,024 admissions and 5,560 days of care and an average daily census of 179, so we'll be about 879 patient days of care below budget for the month. The average length of stay for August was lower than budget at 4.79. The budget had anticipated 5.43. So we continued to have the census-related issues in August. Preliminary information indicates that inpatient revenue for the month of August amounted to approximately $126,105,000 compared to the budgeted estimate of $130,387,000. Of this amount, 46.2% was Medicare and 7.5% was Medi-Cal, or a total of 53.7% for program revenue. This compares to the budget that included 49.7% for Medicare and 12% for Medi-Cal, for a program total of 61.7%. One of the things we are seeing with Medi-Cal, those numbers have been low for several months, we're starting to see a shift to Medi-Cal HMO, so we'll be watching that. The birthing center saw 178 deliveries in August compared to a budget of 171. August deliveries resulted in 390 baby days. Newborns totaled 180 in the month, so we had one or more multiple deliveries in August. For comparison, there were 179 deliveries in the hospital in August of 2011. For the month of August, there were 375 surgical cases at the hospital versus a budget of 380. This includes cardiac surgical cases that were 5 below the budget at 5. 574 cases were seen at the outpatient surgery center versus a budget of 578, so they were pretty close to what they had expected. For the month of August, there were 440 cases seen in the cath lab, including 61 PTCAs, so they were busier than we've seen them in a while. Total cath lab cases were higher than budget by 81, or 22.6%, and PTCAs were higher than budget by 23, or 60.5%. We'll see that reflected in the revenue when we get to that. Inpatient cath lab procedures were 63 more than anticipated in the budget, while outpatient procedures were 18 higher than the budget. Non-outpatient emergency visits for the month, non-emergency outpatient visits for the month came in at 9,179, just 42 below the budget of 9,221, so that was pretty close to budget. The emergency room recorded a total of 4,166 patients, a daily average of 134, and that was 26 above the budget of 4,140. The Washington, Warm Springs, Newark, Nakamura, Ohlone, and Walmart clinics saw approximately 4,129 visits during August. giving us total system emergency room and clinic visits that came in at 8,295 compared to a budget of 8,509. Full-time equivalents for the month of August totaled 1,466.6, including 1.5 agency personnel. This was lower than the budget of 1,587.4, so again, we worked pretty hard to flex down with the lower volumes. FTEs per AOB still came in at 7.19, above the budget of 6.83. Productive FTEs were below budget by 137.4. Non-productive FTEs were above budget by 16.6. So in summary, August had 49 fewer admissions and 879 fewer patient days than anticipated in the budget. Surgical cases were below budget by 5, and cath lab procedures were above budget by 81 for the month. Outpatient visits for August were 42 below budget, while the ER visits were 26 higher than anticipated. Clinic visits for the month were below budget by 240 or 5.5%. Total paid FTEs were below budget by 120.8 for the month and below the last 12 months average of 1,559.6. FTEs per AOB were above budget. Inpatient charges for the month were lower than budget, as we mentioned, by about $4.282 million. Although outpatient charges were higher than budget by $5.224 million. So we ended the month with total charges about $942,000 above budget. On August 31st, we had 159 days cash on hand, so we saw a pretty good increase in that during the month. Total days revenue and accounts receivable were 60.73. Days revenue and accounts receivable excluding Medi-Cal were 54.69. And during the month of August, we saw $918,947 of charges that were approved or pending for charity assistance, and that's a lower number than we've seen in a while and reflective of the lower volumes we've seen over the last several months.
Yeah.
So.
Yeah. Okay, well, thank you, Chris. Any questions? All right, then, are there any other items for discussion tonight? Jan, do you have anything? Okay, any board members? Okay, is there a closed session?
No.
Calendar? All right, well, thank you all for coming tonight, and this meeting is adjourned.